video you have just watched is a very realistic representation of the moment captured by our patient Danny Smith during her water skiing accident. On a water skiing trip, Danny twisted her knee to the side while skiing. Losing control, she then hyperextended her knee. The force from the twisting resulted in a grade 1 medial ligament strain, and the hyperextension caused a full ACL tear. Paramedics arrived at the scene, and a family member provided important information regarding Danny's personal details, past medical history, family history, and social history. The personal information recorded was female, 21 years of age, breathing and conscious upon arrival. Her pain was at 7 out of 10, and she had an aggressive temper. Her past medical history included fractured head of radius at the age 15 from a fall off a horse, mild exercise-induced asthma, she uses Ventolin, and paracetamol is used when required. Her family medical history includes type 2 diabetes in her mother, asthma for her father, and her grandfather has prostate cancer. There is no incidence of cardiovascular disease within the family.
Danny's social history includes her work as a waitress and a full-time student. She has a poor diet with large amounts of fast food. She drinks alcohol 3 to 4 times a week. She is a recreational drug user on the weekends, and her hobbies include horse riding, chess, and yammying. The paramedics' role in this case. The paramedics determined what analgesics are appropriate for this scenario and performed the appropriate first aid. Her doctor, after scheduling the ACL repair surgery and explaining the precautions that are needed to be aware of, prescribed an analgesic for the following few days post-injury. One option is codeine.
Codeine is generally administered in the form of codeine phosphate, as is an opioid analgesic that is used to treat mild to moderate pain. Codeine works within the CNS as an opioid agonist. It acts as an analgesic by being converted to morphine, but only 10% of the dosage does this. It is thought that it alters the perception and emotional response to pain. However, the therapeutic effect is dependent on the patient's age, previous codeine and opioid use, and medical conditions. The 3 receptors, mu type, kappa type, and delta type. The receptors are coupled with G proteins that act as positive and negative regulators of the effector proteins. Opioids decrease intracellular CAMP, which inhibits the release of neurotransmitters such as P substance, GABA, dopamine, acetylcholine, and noradrenaline. It also inhibits the release of vasopressin, somatostatin, insulin, and glucagon. Pharmacokinetics. The absorption and distribution of codeine, which was taken orally by Danny, is absorbed through the GI tract, and onset of action occurs at approximately 15 to 30 minutes. The bioavailability is approximately 90%, and maximum plasma concentration occurs at about 60 minutes. Volume of distribution is 3 to 6 litres per kilogram, and 7 to 25% bind to the plasma proteins. Codeine can be found crossing the blood-brain barrier and is also stored within the skeletal muscles. Codeine enters the system inactive. There are 3 pathways codeine can undergo within the liver. 5 to 10% is converted to morphine by enzyme CYP2D6. 70 to 80% is converted to codeine 6-glucuronide via enzymes UDP glucuronosyl transferase to form codeine 6-glucuronide. 10% undergoes 9-N-demyelinathan to form norcodeine via the enzyme CYP3A4 to form norcodeine. Morphine and morphine 6-glucuronide are active and have analgesic activity. Norcodeine has no effect. It is excreted through the kidneys. Only 90% of the total dose of codeine is excreted, and 10% of that is inactive. The plasma half-life of codeine is 3 hours.
Okay, so 30 to 60% of codeine is 30 to 60 milligrams of codeine is administered every 6 hours, depending on the patient's weight, the severity of their pain, and their age. Codeine may increase the depressive effects on the CNS when combined with alcohol, and this is something to take into consideration with our patient. Tranquilizers, hypnotics, and sedatives mixed with codeine potentiate the effects of the named drugs, so it's really important to avoid this bad mix of drugs. Codeine should not be given to intoxicated individuals and should be prescribed with extreme caution to individuals with obstructive respiratory diseases, as it can exacerbate these symptoms. This is something to take note of, as our patient has exercise-induced asthma. It's potentially risky in patients with potentially addictive personalities. This is something to also need to be aware of. So, in summation, the positive effects of codeine, we get a relief of mild to moderate pain and reduce in coughing. Negative effects include vomiting, nausea, and drowsiness, respiratory depression, and addiction, and slow heart rate. So that's our presentation. Just like to say that there was no Eliza's Hunt in the making of this presentation, and that's us done. A+.